graduated from UT Permian Basin. Is a graduate of this medical school, this general surgery residency. Then did a trauma fellowship with Tim Fabian at the University of Tennessee in Memphis, and then came back and joined us here in the faculty in 1993. He was interim chair for 3 years, and then for the past year has been chairman of the Department of Surgery. Please help me welcome Dr. Stewart this morning.
Thank you, Dr. Schernick. Is the mic working? I'll just use this one. So, no, it's good. I'm fine. Thank you, Dr. Schernick. I'm going to talk about NSQIP, the American College of Surgeons program. It has a interesting history that, at least in part, involves the UT Health Science Center, San Antonio Department of Surgery. I think most people are aware of these reports from the Institute of Medicine, To Err is Human and Crossing the Quality Chasm. These two reports in now about 10 years ago really sparked a debate about quality care in the United States and have led to many large performance improvement programs and indeed many programs related to tied to the Affordable Care Act and really government-sponsored health care. So To Err is Human basically said there were about 100,000 people each year who died from complications from medicine and surgery. And this is a quote from Guth, from one of those. It was a header in one of those reports, which I completely agree with. I think too much of the time we settle for being academic experts rather than actually applying what we need to do for patient safety. So with that, I'm going to basically talk about where we currently are here, where we've been. I'm going to give the principles of surgical performance improvement, particularly from the American College of Surgeons vantage. Then I'll give an overview of NSQIP and then happy to answer any questions. The history of healthcare performance improvement is really tied to surgeons. It started for better or for worse. Many people might say worse, but it started in 1916 with a report from Ernest Codman about hospitals. The following year, Codman was very active in the American College of Surgeons. The following year, the American College of Surgeons started the Hospital Standardization Program, which became the Joint Commission for Accreditation of Hospitals in 1952. In 1965-66, when Medicare and Medicaid were developed, a condition of participation was accreditation by the Joint Commission, so it really became the official accrediting body for hospital care. In 86, Health and Human Services basically started something they called the Healthcare Quality Improvement Initiative, which really became what we currently know as AHRQ, which is one of the key federal entities involved in healthcare reform. And really, as a result, in part from those IOM reports, something called the National Quality Forum was started, which in 1999, which is a public-private partnership. And since that time, there's been an explosion of alphabet soup with respect to accrediting organizations. The Don Abedian, who was a physician who was at the University of Michigan, in 1966 wrote really a public health report, which he outlined the domains of healthcare of healthcare improvement and quality. And the framework that he laid out is really what almost all performance improvement programs are based on. He talked about structure, processes, and outcomes. And now if you read the current reports from, in part from the Affordable Care Act, they talk about structure, process, outcome, access, safety, cost, and inpatient experience. He had it right in 1966 with respect to the things that could be attacked or improved that would improve performance in healthcare. So what about the history of the Health Science Center? When we were really, this institution was really out front with respect to this. In 1979, Carrie P. Page worked to develop and was supported by the Department of Surgery to develop what he called Surgical Procedures and Outcomes Computerized Database, or SPOC. This database had 179 variables, including the common variables that are measured today to assess risk. American Society of Anesthesiology classification, functional status, albumin, bilirubin. All the residents and probably faculty at the time remember Dr. Page because he would beat us to death to get the functional status correct and the ASA correct, and that was prospectively entered at the time of the procedure. And then there were complication records that were completed weekly, or were supposed to be completed weekly, which his goal of that was to basically have a denominator that had risk variables in it from the patient and to tie that to complications. And to computerize it. At the time, there was no Windows operating system. It was initially all developed on punch cards and over in the institutional office that had the mainframe computers. He developed the input form for that, which he cleverly turned into a preliminary op note, so that it was done with the guys, and it was a lot easier to fill out that form than it was to write a standard op note, which it wasn't, but it was. It basically captured pretty much everything that the surgeons did at the time and tied it to complications. In 1991, really the late 80s, the VA was under, the VA finds itself periodically under scrutiny and attack, and the VA was under scrutiny at the time for outcomes in VAs across the country, and so they were tasked with coming up with to show what outcomes were in the VA. Well, as it turns out, Fred Grover, who was a thoracic surgeon here in the Department of Surgery, who went on to be the chair, just retired as the chair of the Department of Surgery at the University of Colorado, and Dr. Aust were on a committee that was tasked to look at that and to try to figure out how quality could be measured in surgical care at the VA. And since both Fred and Dr. Aust had experience with what Dr. Page had done with respect to this SPOC database, I'm sure they contributed strongly to the notion of what this should look like. And what came to be was the National Veterans Affairs Surgical Risk Study, which eventually becomes what we now call as NSQIP. And that same group in 1996 looked at what was a very new idea at the time. When they looked at all these hospital outcomes in the VA, initially 44 hospitals, what they saw that there was wide variance in outcomes with respect to how the patients did. But when they actually stratified it, what they found was that the largest determinant of that was the preoperative risk factors for the patient and to some degree operative complexity. So in 1996, they published what really was a landmark paper with respect to this, looking at risk-adjusted outcomes. And for those of you who remember Dr. Oust, he would always talk, he tied albumin to this. The albumin was the leading predictor, and so he gave whole talks. He gave a grand rounds on albumin as a predictor of this. But really, I think if you were to look at that and take a step back, you would say that, well, in 1979, the Department of Surgery, really led by Dr. Page, was really out in front with respect to this notion that you could computerize the data and track it effectively, and that became NSQIP. So what's our current status? Where do we sit right now? Well, we have electronic medical records at all sites. We have surgical, I'll talk about what SCIP is in a minute, but we have it's not NSQIP, we have SCIP, Surgical Care Improvement Program measures being reported at all the hospitals we work at. We currently use the old SPOC for billing and counting the patients. We've used it for academic work, but complication tracking in SPOC was stopped in 1997. We have individual components of the Department of Surgery using registries that try to include all their patients. The trauma registry, the trauma quality improvement program, none of those didn't exist prior to the past 15 years. The thoracic surgeons use a registry from their national organization, and VA has continued NSQIP, has their variant of the original program has continued in the VA. Otherwise, I'd be curious if anyone can tell me what our risk of complications, what even your own risk of urinary tract infection, surgical site infection, mortality, risk-adjusted outcomes. We essentially have no measure of any of those things. None. In spite of EMRs, SCIP measures being reported, we really, I believe as an entity went from being ahead to really being behind. So who currently is using NSQIP, the National Surgical Quality Improvement Program, in Texas? So St. David's, Baylor, Parkland, Doctors Hospital Renaissance, William Beaumont, BAMC, John Peter Smith, UTMB, the Methodist Hospital in Houston, MD Anderson, Ronal and Killeen, Wilford Hall was, I guess is still a customer, Scott and White, Dell, and Dallas Children's. So really, we're pretty much not the only, but Baylor and Houston and us are the only academic medical centers not currently using NSQIP. Who are the current participants? Well, there's a host of them now, and the college shows this and says there's pretty much equal distribution in the different regions, and it kind of looks like that if you sort of come around. South has 100, West 89, Northeast. But the college, they're mainly they're mainly promoting NSQIP. They don't really point out that Region 6, which is Texas, Oklahoma, New Mexico, Louisiana, and Arkansas. Outside of those programs in Texas, there's very, very little use of NSQIP in the central part of the Southwest. If you look, 9 out of 10 of the, I know these U.S. News and World Report don't really mean anything, but if you look, pretty much almost all the major academic health centers who have significant funding are using NSQIP. And people started to write papers about NSQIP as a surrogate marker for resources and quality of care. So what, before we talk about NSQIP, before we talk about how all these things came to be, what are the principles of performance improvement which really are promulgated by the college? Well, it's really four things. This is the college approach, and it almost dates back to Codman. It almost dates back to 1916. So for better or for worse, setting relevant standards and significant standards. They like to set a standard that's achievable, but is a stretch for institutions and programs. That's the way they develop that's the way the trauma system and the trauma verification program of the college came to be. So set a standard, put the right infrastructure in place. As part of those standards, they set those standards that provide infrastructure to provide quality patient care, whatever that means. Collect data, and the healthcare entity then submits to a process of verification in which those processes and outcomes are examined from an external entity. That's really, if you look across the board at the college, that's their approach to, and this is the American College of Surgeons' response to healthcare reform too. Is to improve quality, and by improving quality, you reduce costs. And I believe they've effectively shown that. So what about the performance improvement currently? Well, there's an alphabet soup of entities that really, if you start trying to read what the Joint Commission, the AHRQ, Health and Human Services, CMS, the National Quality Forum, if you read the National Quality Forum, which is that public-private partnership looking at healthcare quality, I would challenge people to read it and really tell me what it means. But particularly, they talk about a taxonomy that's really a foreign language to clinical medicine. So there's essentially a small army of organizations and regulatory agencies who are really involved with respect to performance improvement, and it really is going to be, it is up to us to improve surgical quality. I'm going to try to make a case that without surgeon commitment, efforts to improve quality are essentially, it's definitely very much swimming upstream, but in some instances it's completely fruitless to actually move forward with the quality initiative without the providers and key stakeholders involved. So, but those agencies, organizations really use four broad tools for their ABC work. They work on quality improvement initiatives, public reporting, accreditation, and payment applications. So they've tied the top three to payment. So those are the tools that are pretty much used. And if you look, 1 and 3 are really from the college. That's their approach. Quality improvement, accreditation, and they leave off the infrastructure required to provide care here. But that's what most of those agencies, entities use. So what is the Surgical Care Improvement Project? This is a Joint Commission project started by, remember, the Joint Commission accredits hospitals. They're currently no longer the sole accreditor of hospitals, but they were for practically speaking forever. So this is a Joint Commission project where they took data with respect to surgical site infections, mainly DVT prophylaxis, and they tried to do some preoperative, postoperative care with respect to beta blockers and prevention of pneumonia. But primarily these measures are aimed at reducing infection in DVT, and they take these data, they've mandated, well, they don't mandate, they say it's voluntary. You can voluntarily participate, but if you don't participate, you have a 2% cut in Medicare reimbursement. So they've mandated basically submission of these measures in a discharge data set. And you'll find when you really look at this that many of those organizations really use discharge data. And so discharge data sounds benign enough. However, the discharge data that's being used for a lot of these projects it's really hospital coding data. It's not clinical outcomes. It's not clinical measures. When the chart is abstracted by the coders at the end of a hospital stay, that's what's being used for a lot of these data. And if for the senior people in the room, you could imagine what those quote outcomes look like, because there's lots of other factors that go into how those things are coded accurately or not. So what are the skip measures? The prophylactic antibiotics given within an hour of incision, prior to incision. There's a list of prophylactic antibiotics that are, there's a checklist that's, the data is cross-referenced to see whether the correct antibiotic was given, whether those antibiotics are discontinued within 24 hours. For cardiac surgery patients, whether the patient's glucose was in range at 6 a.m. on post-op day number 1. And surgery patients who had appropriate hair removal, that means no shaving. Whether the Foley was removed on postoperative day number 2, if someone was on a beta blocker, was it continued postoperatively? Whether recommended DVT prophylaxis was given, and DV prophylaxis before and after. So they looked. So there's a screen of that data to see whether the prophylaxis was started before the operation and whether it was continued for at least 24 hours. That's SKIP. Hospitals are very, very interested in this because it's one of the core measures that are going to be tied, and some of them are tied currently to hospital reimbursement. And particularly the hospitals that have a lot of Medicare patients, makes it's a pay for performance measure. So does SKIP work? It's a reasonable question. Well, it's interesting. If you look at from 2006 to 2008, there's as everyone recognized, there's going to be pay for performance. There was an increase in SKIP, at least reported SKIP adherence. But remember, this is reported because by I mean reported, it's abstracted in the discharge data. That's where this information comes from. But if you look, as SKIP adherence rate increased, actually over that same time frame, postoperative infection rates increased. So there's some question whether SKIP actually works. So where did all this focus on measurement really come from? Well, of course, it predates 2002, but in 2002, Weinberg, Fisher, and Skinner published a paper, and there was a paper published in the New England Journal about variance in healthcare outcomes looking at these discharge data sets in the U.S., and this led to the Institute of Medicine doing its third report, looking at performance measurement. They looked at to err as human and crossing the quality chasm, and they basically became, and it's understandably discouraging, but they basically became discouraged that you can say we have a quality problem, but nothing really changes. So there's a really strong push to measurement, and you see it now. You see in healthcare reform, in the Affordable Care Act, you see tons of measurement reporting from healthcare entities. There's really a belief that measurement leads to improvement. And I would say this is probably the most. First of all, I think most providers are. I'm to overstate it. Most providers are blissfully ignorant about this. They're practicing medicine, practicing surgery. If you look, hospital administration, physician executives, they're not. And the people who've actually looked at this, I would say all of these measurements using discharge outcome, discharge data, leads to the most conflict and the most serious debate about whether any of this makes any difference or not. In fact, even hostility. So Massachusetts looked at this Massachusetts looked at this at these at the discharge data sets, which all claim to do risk-adjusted outcome, which all use some risk adjustment. They basically say we can take that discharge data and through manipulation or through looking at it, they basically say we can risk adjust it. Well, the short version is that the commonly used systems that do that don't do it. In that they, if you look at the different methods that are currently being used to do that risk adjustment, if you look, the outcomes look totally different based on what method was used to calculate, to do the risk adjustment. So the same hospitals were classified as higher than expected by one method and lower than expected by another. But it is the predominant, those discharge data are the predominant measurement of healthcare quality by CMS currently. We don't have time to go through this data, but there are other performance measures. The National Quality Forum has been one of the leaders with respect to establishing performance measures and benchmarks. To establish a performance measure, lymph nodes and colon cancer, the AHRQ patient safety indicators. AHRQ said that they could look at, that they could determine which hospitals were high performing and low performing based on using this data. Head of bed elevation to prevent nosocomial pneumonia. In short, there are problems with every one of those things with respect to whether they're accurate or not. It is true that if you look at hospitals that have, I just won't delve into it, but it is true the lymph nodes and colon cancer debate. It is true if you look at hospitals that have higher numbers of lymph nodes in the specimen, that those hospitals tend to have better outcomes. However, when you tie it now to individual patient outcome and you do risk adjustment on the individual patient, you find there's many other factors. That same correlation doesn't, for example, work in the same hospital. So there's other factors in care that are being delivered that impact outcomes from colon cancer. So we should all have healthy skepticism about these things. Dr. Hahn summed it up in an invited commentary about these performance measures. Basically, she said the pursuit to create metrics that can be measured, practices that are less effective than those targeted for improvement may have been created. In other words, the program that's designed to do the performance measure, what you're targeting may actually be worse than what you started with, which leads to performance measures for performance measures. Probably most of you don't remember, we remember it, but the bee watcher, Dr. Zeus, if you want the bees to work harder, you need a bee watcher. And when that doesn't work, then you have a bee watcher. You have the watcher of the bees watching the bees and a watcher. That's what you come up with. So it's a whole, I'm looking for Michelle, there she is. You get the watcher, you get the bee watcher. And now, I would say, if he were alive today, he would say, now we need the bee measurement watcher. We need to measure how much those bees are producing, and we got to watch them. And we got to measure it, and by the way, we need a performance measure for the performance measure for those bees. It reaches a point of absurdity. So how should we measure whether these performance measures are actually do what they say? Well, so you can look at them in 4 different ways. Are they accurate? Does the coded outcome equal the clinical outcome? Are they generalizable? Can this be generalized to a different sample of patients? In other words, if you look at you look at a performance measure at the Mayo Clinic, does that generalize to San Antonio? Does something in San Antonio generalize to Minnesota? Is the performance measure reproducible? And lastly, is it transportable? By transportable, are the methods used to do it transportable to other healthcare settings? And then the probably least studied of it, is it geographically portable? In other words, what that means is, if we do a study here with respect to a performance measure, does that translate at all to Hill Country Memorial in Fredericksburg? Does it translate at all to Uvalde? Well, the answer is no one knows. And indeed, there's problems with each of those criteria. So as these things move forward, they really need to be studied whether this is actually effective or not. So summarizing the discharge data, it's relatively cheap. All the hospitals do it in one form or the other. Now, they all do it to some degree differently based on what their coding resources are and how their coders do it. But it's readily available, and it's increasingly available with EMRs. In fact, that's one of the goals of the Meaningful Use Project. If you look at meaningful use, the goal is to get everyone in an EMR. Then you can have data that you can measure quality with. And that's really a key part of the move to EMRs, is not to just get people in EMR, but get hospitals and physician organizations in EMRs so that you can measure quality and, quote, outcomes, unquote. There's problems, though, as I said, with respect to all those things. It reminds me of the opening stanza from The Rock, where T.S. Eliot is talking about the modern era, and you really get the sense that with respect to where we sit in some of the information age, we are drowning in information that doesn't lead to knowledge, that doesn't lead to wisdom. So problem. So what are successes? There are some successes, and obviously I entitled my talk Misquip, so obviously I think it's a success. There was a study of 183 hospitals in 2005 to 2007 where over the time period of them using Misquip, there were significant improvements in risk-adjusted mortality, morbidity, and that was across all hospitals, whether they were low-performing in the beginning or high-performing in the beginning, that they all, to some degree, improved. Preoperative risk factors and surgical complexity were the most predictive of outcome. And the other success in surgical care has been surgical quality collaboratives. So there's the SCOPE program from the from Washington State, which is a voluntary collaboration of hospitals and healthcare organizations who've looked at improving quality. The Tennessee Surgical Outcomes Collaborative and various NISQIP collaboratives, the first being from the University of Michigan. Those geographically different entities have shown that if you get surgeons across different healthcare entities together and have them talk about outcomes and work on improving performance, that their outcomes tend to improve. Now, it's something to think about. It's not, I don't have an answer for it, but it's you should be skeptical of all of these things, including what I'm saying. So it does, in some way, beg the question of, if you remember that the early days of NISQIP, the top 10 variables that predicted outcome were related all to patient risk factors and to surgical complexity. So the skeptic would say, well, that's really great. So if that's the case, then how do you modify that? How can you improve mortality by 62% if you have the same patients and the same operations needed? Well, the short answer is I would assume that when people start looking at these risk-adjusted mortality, they stop operating on higher-risk patients or delay those operations until those risk factors are improved. So what is NSQIP? Well, it's a web, in its current iteration from the college, which is the commercial, private, academic program. It's web-based. It has the built-in quality improvement tool. It does risk-adjusted outcomes based on that original work done from the VA. It's been validated in hundreds of hospitals. It's audited by program auditors in NSQIP to see whether the data is consistent, internally consistent, and consistent compared to benchmark. It uses 30-day follow-up. It's targeted. The core of NSQIP is targeted to general surgery and vascular surgery. Although there's multi-specialty as well, particularly OB-GYN, neurosurgery, and cardiac surgery. And it allows for benchmarking. It allows for comparison of where your hospital or program sits relative to the rest of the country. The data is abstracted. It's done with a manual abstraction from the medical record, so there's a person who does that abstraction. It's, like I said, web-based. There's online training and actually physical training. NSQIP produces semi-annual reports which have the risk adjustment. And then what they've done with the program as well is work on best practices. In other words, they've looked at NSQIP sites that have the best outcomes, and they basically have those guidelines that are in some ways now off the shelf from programs that have improved already. So you're not reinventing the wheel. And you can there's an online risk calculator that you can actually take an individual patient and plug that patient in, look at what their predicted risk using the NSQIP data set would be. Now, I'll give you more things to be skeptical about in a minute. The way the program is set up, there's a surgical champion, and there's what they call a surgical clinical reviewer. This is the person who abstracts the charts, who collects the data, who works with the operating rooms and the clinics, and that they correctly emphasize that surgical clinical reviewer, that their work needs to be honest, respectful, that there needs to be a close working relationship between the surgical champion and the surgeons and that surgical clinical reviewer. And it needs to be someone who's in that needs to basically be somebody who can develop and who wants to do that and wants to basically have good results. NSQIP collects a wide variety of data: demographic, surgical profile, preoperative risk information, intraoperative data, and postoperative outcomes. The case selection is there's a sampling of all operations requiring anesthesia. NSQIP excludes trauma, transplant, ophthalmology, C-sections, endoscopy. So trauma and transplant, which are for university hospital, are big volume, complex outcomes. Group of patients are excluded, and some of the lower risk procedures are excluded as well. NSQIP doesn't do the Carrie P. Page approach of putting all the patients in there. It uses a random sampling based on an 8-day cycle, which has been worked out among the sites. Uses a random sample to do that. There's 30-day follow-up review, which is completely dependent upon the reviewer. to arrange for that, which can be a review of the medical record. These are all the techniques the college recommends using. This is data from the college echoing my point that if you look at administrative, administrative data, that's what they call the discharge data, that administrative data misses 61% of complications, including 100% of urinary tract infections and 80% of wound disruptions. In other words, if you don't have someone going through the chart looking, or someone who's actually talking to the care providers, you miss a lot of those things. The benchmarking is done by calculating an odds ratio, where 1 is essentially the benchmark average for for all NISQIP sites, and so based on that odds ratio, you can list your site within statistical ranges of how your site outcomes compare to everyone else. This is a slide, actually a variant of the slide that came from that 1996 paper. Dr. Alice was the senior author. That if you look at unranked mortality by hospital, and so you rank them 1 to, this is those original 44 VA hospitals, 1 to 44, and then you do the risk adjustment, you can see that there are all sorts of changes with respect to that risk adjustment. So hospital B, for example, that was at number 37, is now number 7 when that data set is risk adjusted. So they make a strong effort to risk adjust those data. The data is audited internally in NISQIP to look at whether there's agreement between the surgical reviewer and other reviewers. There's a real-time and semi-annual report. The real-time is non-risk adjusted, but for example, if we had NISQIP when we were using it, we could walk over right after this conference and we could basically look at what our outcomes. It's just not risk adjusted. So twice a year you get a risk adjusted report comparing your site to the national benchmarking sites. This is just an emphasis that you can get real-time reports. You can get a preoperative risk factor summary of how your outcomes were based upon NISQIP risk factors, and a 30-day post-op report where you can pick out of that report your outliers in your own institution. And you get a mortality report that summarizes all deaths in the institution that were identified in NISQIP. There's about 60 risk-adjusted outcomes that NISQIP currently looks at, not just mortality but 60. These include mortality, morbidity, cardiac pneumonia, unplanned intubations, ventilator dependence more than 48 hours, DVT-PE, so a whole host of risk-adjusted outcomes, and you get those reported in statistical ranges comparing how our site or the local NISQIP site compares to the rest of the NISQIP world. So does surgical quality improve using NISQIP? Well, I've already talked about this. In that report, 82% of NISQIP hospitals decreased complications. There were significant decreases in mortality. And so by avoiding complications and bad outcomes, this is an extrapolation, but these surgical complications are very expensive, and so individual hospitals may save lots of money with respect to avoiding even a handful of the worst complications. The college has reports, essentially success stories from multiple different NISQIP participants. And in general, the hospitals that participate in NISQIP in general are advocates of participating in NISQIP. The surgeons, there was a survey of surgeons at 3 different entities, and in the hospitals that had implemented NISQIP previously, the surgeons were more skeptical than the surgeons who hadn't implemented with respect to how accurate NISQIP was and how much it helped. But so there's other non-monetary benefits. I believe that having a valid national benchmarking for surgery outcomes is very important that surgeons do that versus non-surgeons, because it's going to be done. The question is it going to be done using clinical data, or is it going to be done using administrative discharge data? So I think it's important that we do that. It helps look at cross-departmental partnerships and collaboration through sharing of knowledge. For example, there's many, if you look at a lot of this NISQIP data, there's some common denominators between general surgery and obstetrics and gynecology with respect to outcomes. So, and you can get CMEs for the people who are involved, and it counts for your maintenance certification for surgeons. So the other thing that the college really promotes is best practice guidelines. Those are basically accumulated from pre-existing NISQIP sites that they work on trying to make those evidence-based. They obviously have a large expert panel to pull from, and provides a framework for individual hospitals to do performance improvement programs that they may not have done otherwise. The data is general surgery and vascular surgery, and the multi-specialty data set is, as you would guess, expands that to cardiac, gynecology, neurosurgery, orthopedics, ENT, plastics, thoracic, urology. So what does it take to do? How much work is it to do this? Well, for general surgery, for the core NISQIP, it samples 1,680 surgical cases per year in that 8-day sampling cycle. This can be done with 1 FTE, so that one surgical reviewer can keep up with this. Now, people who've done NISQIP, there's a push to do, so once you've done NISQIP, you can actually target, if you want to target a specific procedure or set of procedures, you can target outcomes there, so that now then you get not just so for example, some of these procedures would hardly show up in an 8-day sample, so institutions can target what they would like. How much does NISQIP cost? It's a hospital-based program. It's not quite $30,000. The college discounts it to get people doing it. If you have a system or you can work out a deal with them, they will discount the price. But so it's about $25,000 plus the cost of the surgical reviewer. The Joint Commission has really come on board to promote and support NISQIP, and as I said earlier, it meets the American Board of Surgery maintenance certification for evaluation of performance practice. So if I were to summarize, we really began with the lead in measuring outcome. We're currently behind. NISQIP is, I believe, our best tool to move forward with respect to measuring surgical outcomes. I've outlined what I think are the advantages of it, and probably one of the strong advantages for doing NISQIP is that if you're putting your data into NISQIP, it can foster local collaborative. For example, there could be right now there's no non-federal sites in San Antonio that are using NISCRIP, but if everyone was using NISCRIP, people start to speak the same language, much in the way that that people did with respect to ATLS and trauma care. Once people are using the same language, using the same system, it tends to facilitate collaborative. So I started with a quote from Goethe, and then I think it's important for us to move forward aggressively with respect to measuring outcomes. That right now, if you look in South Central Texas, I think we've debated about what we should do, need to do, what we can do, but really, we've made a decision. We need to go ahead and move forward with NISCRIP, and once we do that, I think it will pay dividends. So I'm happy to answer any questions.
Any questions for Dr. Stewart? Next question.
More than a question, a comment. I mean, I think our legacy suggests that we ought to embrace this rather quickly, and I tend to agree. Some of the important points of the original NISCRIP, in particular, the reviewer, the abstractor, has to be independent of the surgery department. And in fact, in the VA, it was really, we didn't even really know who was doing the reviews. They were totally independent, so they couldn't be influenced by anybody or anyone within the department, and it meant that the data presumably was valid. There is a weakness in the system where you use a surgeon to do the abstracting, for instance, from the department. So NISCRIP has that built in, and that's a protective. It does work. The more programs you have involved, the better, because you get a much larger database, and you can select out more easily the outliers. And one of the interesting phenomena that I saw when I was an officer in the Association of VA Surgeons, I was asked to review a program that clearly was an outlier, and it was obvious, based on outcomes data alone, that large, not-to-be-named program was failing because it was sitting a little geographically removed from the native academic center, and it didn't have anybody as faculty positions visiting the place. So by identifying it as an outlier, the VA targeted that program and insisted on immediate improvement, and then they did occur. So it's effective when used correctly, and I think it's an ideal program for here.
Dr. Stewart, with the 100,000 unnecessary deaths, is there any breakdown as far as who are the guilty people? And then is it internists, hospitalists, ER doctors, pharmacists, nurses? And the reason I ask that is, surgeons have been doing M&M since the first operation. And, we kind of pride ourselves in doing that, especially at academic institutions. But are we doing better than our colleagues, or there's still room for improvement?
I don't know whether we're doing better or worse than our colleagues, but the guilty parties are both surgery and medicine. If you look, I removed it from the talk, but if you look, the universal protocol reducing wrong site surgery, getting the right patient, that's what they all know the drill. Have to go sign the site, identify the patient. It's a little depressing when you actually look at outcomes before and after that. There still is a lot of wrong site surgery being done. In that, if you look who it is, it's the surgeons and the medicine doctors both. They're both doing it, and so it's probably everyone in medicine. It's not something we can pan off on internist is being, it's all of us.
No, I was just hoping that we did better just because we do have morbidity mortality.
Well, it raises the point that I've made over and over. M&M is the sorry equivalent for something as elegant as this. I mean, because there isn't any feedback. We discuss the same cases year after year. I don't know that it makes a big difference.
I think, and I would say, and just to come back to Dr. Schweitzer's comment earlier too, is the weak spot of the original Health Science Center database. It was not, the computer turned out to work, they put in the note in at the same time, captured the great majority of the patients. The weakness of it was in collecting the complications each week. It required a huge amount of effort to do. It required surgeons to voluntarily participate to do that. But even the ones who were totally willing to participate and who wanted to participate still missed complications because they're busy people. So I think you're exactly right that the random sampling of having an independent collector. Now, the college's view of this, and they emphasize it heavily, is that it should not be independent of surgery. It should be someone who's involved with the surgery program, but independent enough that they basically can abstract that chart, but they're working with the surgeons as a team.
One of the sites that's missed continually is the ambulatory surgery center, especially for wound infection follow-up.
So depending upon NISQIP would be set up here, it might be missed here, but NISQIP itself, you can incorporate your ambulatory surgery center and fine. Someone's trying to call us.
ET phone home. Yes.
Somebody answer the phone.
I'm trying.
I'm curious why transplant was still excluded out of the process.
Yeah.
What was the rationale behind that?
No.
Sorry, Dr. Esprell.
So this I don't know the answer, but I'll say what the college representatives say is transplant was excluded because the patients are on a lot of immunosuppressives and they look as an outlier group when you start looking at infectious complications and complications. So that's kind of the answer. The other part is that transplant is pretty heavily monitored with respect to UNOS and transplant outcomes are recorded. So I asked, well, why is trauma excluded? Why would you exclude trauma? Well, again, the answer is, well, it's a specialized subset, but probably there's another answer too. They have the trauma quality improvement project that but most verified trauma centers use, and so they're selling two products, PQIP and NISQIP. Dr. Bean.
Just two quick comments. One, I think with regards to the M&M, I think it's kind of human to not want to self-report. Even though we say we want to do it, I think the tendency is to sort of not self-report, and I think that's just it. Then regarding the comment about the naysayers about maybe by risk avoidance we have falsely inflated these things, especially when you look at the original 10 NISQIP criteria. Interesting article in last month's Journal of the American College of Surgeons where they actually went back and looked at 6 high-risk procedures. They looked at over 2 million cases, and then they kind of modeled it and tried to adjust those things. And by strictly avoiding high-risk patients and stuff, even in those high-risk procedures, they were unable to show that you would actually improve mortality by just avoiding those patients. So they can't really game the system. In fact, that's the title of the article. Interesting read.
Alrighty. Thank you very much.